Hello, my name is Kelly. Welcome to the NICU Now audio support series. I am a NICU parent to Jackson, a micro-preemie born at 24 weeks, and Lauren, a late-term preemie born at 34 weeks. I am also the founder and executive director of Hand to Hold, a national nonprofit dedicated to providing education, resources, and peer-to-peer support to families that have experienced premature birth, the loss of a baby, or have a child with a special healthcare need. As technology and neonatal medical care continues to advance, the cusp of viability continues to be pushed back, which means more babies are surviving at earlier gestational ages. But these babies and their families face long and most likely difficult NICU stays, filled with surgeries, medications, and therapies that span years and sometimes a lifetime. Parents are often just as fragile as their tiny babies. While their wounds are not as visible, their trauma is just as acute. NICU parents often face their own long-lasting challenges, including mental health diagnoses such as anxiety disorders, depression, and PTSD. Studies also indicate that these challenges often result in higher rates of divorce, child abuse, and neglect. For more than a decade, hospitals have embraced family-centered care models that recognize parents as mutually beneficial partners in the care of their babies. But how can we expect them to function as mutually beneficial partners with the care team if they are struggling to understand and address their own psychosocial issues? In order for all NICU babies to thrive after discharge, they need smart, informed parents who understand their needs and are emotionally and physically capable of caring for a medically fragile child. A group of dedicated medical and mental health professionals, including neonatologists, psychologists, social workers, and developmental care specialists, and NICU graduate parents worked together for more than a year to draft psychosocial support guidelines for NICU families, which were published in a supplemental issue of the Journal of Perinatology in December 2015. It is the work group's intention to ensure that medical professionals and hospital systems recognize the need and importance of psychosocial support for NICU and bereaved families, and view this support as equal in importance to medical care for NICU babies. Joining me now to talk about psychosocial support for NICU families is the co-chair of the National Perinatal Association's workgroup on interdisciplinary recommendations for psychosocial support of NICU parents, Dr. Sue Hall. Dr. Hall has been a neonatologist for 25 years. Prior to her career in neonatology, she worked as a master's level social worker. Working in both fields, she truly understands not only the medical challenges faced by the babies in the NICU, but also the emotional challenges parents face during a NICU stay. She is a BA from Stanford University, an MSW from Boston University, and an MD from the University of Missouri, Kansas City. She is now in private practice at a community hospital NICU in Southern California. She is also the author of a book about life in the NICU titled For the Love of Babies, published in June 2011. Welcome, Dr. Hall. Dr. Hall, thank you so much for being here today to be part of our NICU Heroes podcast series.
Thanks so much for inviting me, and I'm thrilled to be with you today.
I think it's only fitting that you are a guest on our NICU Heroes podcast because I do think of you as a NICU hero, and I know so many other preemie parents do as well. Not only are you an amazing neonatologist, but you truly are a champion for mental health support services for NICU families. So I just couldn't be more honored that you're taking part in this.
Well, thank you again for inviting me. It's an honor to be here.
Well, I'm going to ask you to start by telling us why you and the National Perinatal Association were interested in convening a work group to address the psychosocial support needs of NICU and bereaved families. Why was this important to you and an MPA?
Well, I think the main thing is that we were hearing from a lot of parents just like you about what their NICU experience was like after they've had some time to kind of recover and think about it and look backwards. And parents were just telling us over and over again how stressed they felt, how difficult it had been, how little support they had gotten, and they wondered why it was that way and why it couldn't change. So in neonatology, we have so many protocols and standards for all different types of care, for ventilator care, for skin care, for nutritional care, all of the medical aspects. I just thought, why don't we have some standards for psychosocial care? Let's really pull together all of the recommendations in different areas that have already been made, but not really seen as a group of recommendations that all go together towards supporting parents. So we just wanted to bring it to the forefront of people's thinking about the NICU experience, and so that's why we went forward with this work group.
Well, let's take that a step further. I mean, why do you and the work group feel it's important to view mental health of the NICU parent, the NICU family, as equal in importance to the NICU baby? Why do you want them to be equal?
Because it doesn't really do anyone any good to send home a baby that is physically healthy but perhaps hasn't been emotionally cared for in the best possible way. And similarly, it doesn't do anyone any good to send parents home who are stressed out and worried and so forth. So to optimize the development of the baby, the neurologic and neurodevelopmental progress of the baby, it's really important that the families be as mentally and emotionally healthy as possible to be able to support their baby and interact with their baby.
How do these psychosocial issues impact the parent's ability to bond with the baby in the NICU and after discharge? Can you just go into that in a little more in depth of how is our mental health issues keeping us from bonding with our baby?
Well, first let me say, you're describing mental health issues. Most of the quote-unquote mental health issues that parents have in the NICU are completely normal responses to what is surely a very abnormal situation. So that's the first thing I want to do is say we're not talking about parents who have serious mental health issues for the most part. The NICU doesn't make you crazy or anything, but it's normal to feel frightened, to feel guilty, like there's maybe something you did that caused your baby to be born early or to have some problem. And so those fears and feelings of guilt can get in the way of parents connecting with their babies. Also, the NICU environment, just the high technology aspect of it, seeing a tiny baby that they were unprepared to see in an incubator with, plastic walls that sort of separates them from the baby. It's just a hard thing to come up against emotionally for parents. So I have the perfect example just from my practice yesterday. I was with a mom, a first-time mom of a baby who was born at 30 weeks. And the baby was pretty stable, was on some CPAP. And I said to her, I want you to do skin-to-skin care with the baby today. And she said, I really want to wait because the baby's too small and I'm afraid something will happen. And I could just see that hesitation in bonding. Maybe things aren't going to turn out well. Maybe I'm going to make things even worse than I've, quote unquote, already made them. And so we just had a little talk about how important the mother was to her baby's growth and development, and also how important the baby is to the mother's well-being. That connection is really what this whole issue is all about, promoting that connection so that the mother can guide the baby's brain development. So she finally agreed to do kangaroo care, and I think she held the baby for several hours, and then the nurses told me when she left the NICU she was just overjoyed with how wonderful an experience it was. So I felt like we were making some progress, even though she hadn't said, I'm scared, I'm feeling badly, or anything like that. Those emotions are present, and the more that we can recognize and validate them, the more we can help parents and babies get together and do what they're supposed to be doing with each other.
Wonderful. Well, I know that you have an extensive library, that you have been collecting research articles and papers about the psychosocial issues in the NICU that NICU families face. Can you tell us a little bit about the statistics that are being shown on anxiety disorders, depression, PTSD? What are some of the studies showing?
Well, in general, 1 out of 7 mothers will have some sort of perinatal mood disorder. And in the NICU, the number is even higher. So baby blues, postpartum depression occur in people who give birth to term babies, and that's about 10% as far as postpartum depression. But in parents of NICU babies, both mothers and fathers, I will point out, have rates of postpartum depression that can be as high as 30%. And this postpartum depression can even present as late as 2 years after the baby is born. So it's like NICU parents have a higher risk of developing depression because of the experience they're going through. Similarly, the risk for post-traumatic stress disorder is about twice as high in preemie parents in particular than it is in parents of term babies. And again, when your baby's in the NICU, you're exposed to traumatic experiences such as watching your baby undergo medical procedures that might be painful or uncomfortable. Your baby might even have near-death episodes, or so you may think, when the baby's having apnea and bradycardia. And the alarms, the smells, all of the things that occur in the NICU can kind of stick with parents and follow them and lead to flashbacks and anxiety and things like that that make up post-traumatic stress disorder. So the whole goal of the psychosocial recommendations is to raise awareness among NICU staff of what we can do to intervene during the NICU hospitalization to decrease parents' risk of developing either postpartum depression or post-traumatic stress disorder.
So that actually was one of my questions of what can neonatal professionals do to help parents, process their emotions and to begin to bond with their baby?
Well, what they can start by doing is just to listen to what parents have to say, to normalize parents' feelings. As I mentioned, it's normal to feel frightened and terrified. Even babies that we as neonatologists know have almost zero risk of dying, such as a 35-weeker. A parent of a baby like that may worry that their baby will die. So these are things that we just have to kind of draw out and confront and talk about so that parents can be reassured that things are probably not as bad as they're worried about. We have to respect parents' wishes for being involved in their baby's care and decision-making, and we have to encourage their involvement. We have to, again, normalize that we want parents to be involved in taking care of their babies as much as is possible in the NICU. And this pretty much requires a culture change among NICU staff people, because historically the approach to neonatal care has been, we have your baby, don't worry, we're taking care of it. As soon as everything's fine, we'll give the baby back to you. But now we're changing more toward, this is your baby, help us help the baby get well through your involvement and caring and concern for the baby.
Well, I know in my experience and my husband's as well that the emotions we were going through, that all of our worries and fears, that it really impacted our ability to effectively communicate with the neonatal team. So what can we do to enhance that communication between the parent and the NICU professional?
Well, I think if communication needs to occur on a daily basis, it needs to be transparent, it needs to be open. All of the parents' questions need to be addressed. And if parents are not visiting or coming to the NICU, and we don't really even like to use the word visitor anymore because that implies the parent doesn't necessarily belong there. But if parents aren't coming into the NICU, then that indicates to us either that they have problems that need addressing, such as transportation or babysitting or something like that, or that they're just so overwhelmed and fearful and stressed out that they can't even handle visiting or coming. So what neonatologists and the whole staff, nurses, social workers, psychologists, if they're present, need to do is try and engage the parents and partner with them, and as much as possible just discuss what their fears and anxieties are so that they can be minimized. Certainly we can't get rid of every fear because some fears are founded in fact. If a baby has a serious complication, we can't just wipe that away, but we can talk about how best to handle it together. We can talk about the range of outcomes that the baby might have and not just focus on the worst possible outcome. And so those are just some of my ideas about communication.
I do want to reiterate, in 2015, the work group published their recommendations for psychosocial support for NICU families in a supplemental issue of the Journal of Perinatology. And I'd like, if that's all right with you, Dr. Hall, for us to just dig into that a little bit more for those that may have not had an opportunity to read these recommendations. I know it starts out by talking about peer-to-peer support. So why did the work group feel that peer-to-peer support is so critical during a NICU stay?
Well, peer support is a modality of psychosocial support that's been around for years and years and years. Think Alcoholics Anonymous, National Association for Mental Illness, NAMI, and they've been quite effective. Peer support in the NICU has been endorsed by the American Academy of Pediatrics, or actually peer support for any type of pediatric situation. And peer support groups started appearing in the U.S. maybe around the late 1970s, early 1980s, but they haven't really had as wide adoption as they should, in my opinion. Peer supporters are veteran parents who've already been through the NICU experience, maybe a year or two or three before becoming a volunteer peer supporter, and they're matched with current NICU parents based on similarities in background, gestational age of the child, things like that. And a veteran parent is probably the best person to be able to really understand what a parent is going through, and also the best person that a NICU parent is going to feel most comfortable expressing their innermost fears and anxieties. Sometimes NICU parents are not really comfortable expressing everything to the NICU professionals. They think it might change how the professionals see them, perhaps. And so a peer supporter is a person who can kind of interpret everything for them, share their own experience, and help guide them through the NICU and help them learn how to become an advocate for their own baby.
Well, in addition to peer support, I know that the work group pointed out several other elements that should be included in what they consider comprehensive family support. So can you tell us a little bit about what are some of the other things that need to be in place for a comprehensive family support program?
Yes. As I had mentioned earlier, we looked at different areas that a lot of people had done work in for parents in the NICU and decided to pull them all together under this label of comprehensive family support. So one is peer support that we've already touched on briefly. One is mental health services, and that includes a new recommendation to have a NICU psychologist if the NICU is large enough to support that. We recommend that every NICU have formal policies for palliative and bereavement care, that they implement family-centered developmental care, that they pay attention to discharge planning and follow-up, because many NICU parents do report that going home with the baby is actually the most stressful part of their experience. And then we looked also at staff education and support, because we know that NICU staff need a whole lot of new tools to be able to implement all of the other recommendations, and they also need support themselves, because while parents know that the NICU is a stressful and traumatic place, they might not appreciate that for staff it can be very stressful and frightening also. And NICU nurses, NICU doctors are subject to secondary traumatic stress disorder, which is basically being stressed from watching other people go through stressful experiences. They're also subject to PTSD, to burnout, compassion fatigue. So it can really take an emotional toll on staff. And so in order for staff to have enough emotional energy to give to the families that they're caring for, they themselves need to be cared for. So that's a big part of the recommendations too.
All in it together. Absolutely. I can only imagine what a stressful work environment that is. I mean, I know there's a lot of joy and celebration and helping these babies reach their full potential, but I can only imagine the stress and trying to be all things to all people. The nurse has such a vital role in playing that peacekeeper and providing the communication and kind of the mediator between the doctor and the parent. So a lot of stress on the medical professionals. Well, let's dig in just a little bit more, because I know that the work group recognized the important role of parents as caregivers for their babies. So what can medical professionals do to support the role of the parent to serve as a participant and, what we call an essential healing partner in the NICU for their baby?
Yes, I think the main thing that NICU caregivers need to do is just envision a shift in their role from being the person with all the answers, who is the expert and only they can do things for the baby, to seeing themselves as more of a mentor and a coach to the parent. So yes, NICU professionals have expertise, but they need to be partners with the parents and kind of on the same plane as the parents. So one is not, revered as the expert and the parent set aside in the corner because they don't know anything. It's more like the NICU staff take parents under their wing, give them confidence to become involved, and show them, tell them how to do things, interpret their baby's behavior, just share their expertise with the parents and family in a way that empowers the family to take on those types of care practices, things like changing the diaper, soothing the baby, feeding the baby, all of those things.
Is that what you would call family-centered developmental care? Can you describe what is family-centered developmental care?
It's kind of a combination of family-centered care, which means partnering with the parents, and developmental care, which means paying attention to the things in the baby's environment that affect development. So paying attention to sound and light and positioning of the baby, responding to the baby's cues of distress, touching the baby in ways that are comforting to the baby as opposed to overstimulating the baby. So family-centered developmental care means involving the family in the developmental care of the baby. And I think the bedrock of that type of care is encouraging families to do skin-to-skin care with their baby. We have to remember that biologically, the mother's brain and the baby's brain are actually kind of interacting with each other. The baby provides a cue, the mother responds to the cue, the baby responds to that. So they're involved in this kind of interactive dance that is facilitating the baby's development. And the mother is the best person to do that, and the mother's chest is the best environment for that kind of development to take place. So we've kind of talked about how neonatology hasn't had any major breakthroughs in treatments or therapies over the last number of years, maybe the last 20 years. There's not even any new medications in the NICU. And so progress in developmental outcomes is very incremental and sort of slow. But what we have in front of us is a mother and a baby, and we haven't really utilized this natural resource, if you will. We haven't leveraged it to the full potential that it has. And so that's really the focus of the recommendations, is to get the baby and the parent back together for the benefit of the entire family.
That's fascinating. It truly is. I mean, when I was in the NICU and Jackson was, a little more than a pound, it was 6 weeks before I got to hold him. And, not being able to hold him for 6 weeks was extremely difficult. But at the same time, I like the mother you described earlier, I was scared to death to hold him. But once I did, it broke down a lot of the barriers and the walls I had built up. And I finally began to feel a connection with him and feel like I could be a mom, no matter what challenges he would go on to face. So I think it's fascinating for us to continue to research that biological connection between the mom and the baby, and the father too. So let's talk a little bit more about mental health. You mentioned the higher risk for depression and PTSD. The guidelines are specifically calling for mental health professionals in the NICU. And I have to say, from my experience and what I know about most NICUs across the country, that's kind of a rare sighting. That's kind of the unicorn. We don't see a lot of mental health professionals in the NICU. So first of all, describe how are the mental health professionals you're talking about different than social workers, and what role is the work group hoping this mental health professional will play? What are the best practices we're seeing across the country?
Well, first of all, let me say that I don't want to discount the importance of social workers. What we are trying to lobby for or advocate for is that social workers will have enough staffing to take care of all the NICU parents, and that they will have time to address parents' emotional needs, not just the sort of discharge planning needs. Sometimes social workers get stuck with case management kind of duties, things that are important, but it doesn't leave them enough time to just sit and talk and provide emotional support to parents. Some NICUs, they are able to, and they do a really excellent job. But we recognize that the needs of parents sort of outstrip the capacity of current social work staffing to meet those needs. And so we have recommended a PhD psychologist, preferably, to work in NICUs, at least those that have greater than 30 beds. So, your smaller little community NICUs, they should try to form a relationship with a behavioral health professional in their community that can be available to consult and come in if needed. But the large NICUs, the academic center NICUs, the children's hospital NICUs, sometimes those NICUs have over 100 beds. Now, those are the NICUs that absolutely need a psychologist. So the psychologist can be available to help parents that maybe have more serious needs than social workers usually deal with, parents who are decompensating or struggling to a greater degree. They can also do screening for mental health issues such as postpartum depression. They can do teaching for parents about infant behavioral development, and they can support the staff. And that is a very critical role. A lot of times, as you know, NICU parents will get labeled as being a difficult parent or something like that. And it would be the role of the psychologist, if the social worker hasn't already done it, to try and interpret the parent's behavior for the staff and put it into a context that they can understand so that they can work more effectively and productively with that parent. No parent comes into the NICU wanting to be difficult, but the stresses that they're surrounded with maybe are reminding them of past experiences that they've been through, or maybe they're just having a really hard time coping with what's going on today. And so psychologists can, again, help the staff understand and work in a better framework with those parents.
Well, you mentioned screening. So No one talked to me about my risk for anxiety disorders or depression. I certainly did not have any screening done. So what would that screening look like? When would that be conducted, and what would we be looking for in those screenings?
Well, the recommendation of the work group, the published recommendations are that every NICU parent should have screening for depression within 3 days of their NICU admission. It's been recommended by the American College of OBGYN and the National Health Task Force or whatever government agency that really all moms should be screened for postpartum depression. And so we want to bring this into the NICU. What it can look like is actually a questionnaire that parents might fill out, a questionnaire that a social worker or a nurse or a psychologist might administer, or it might just be in the form of a sort of informal interview, if you will, just a conversation between one of the mental health professionals and the NICU parent. The psychologists who were working with our work group, and there were quite a number of them, maybe about 10, really differed on how they wanted to approach parents, whether with a formal screening tool or an informal conversation. So the recommendation, again, is to screen parents within the first couple of days, repeat a screen whenever it seems indicated. So if a parent seems more depressed, they might be approached, let's talk about it. And then again before discharge, because a lot can happen during a NICU stay. So if a professional talks to a parent the first couple of days and the parent's kind of holding it together and everything seems fine, well, the professional can't just say, well, I don't need to talk to them again because they're clearly doing well. A lot of things can happen. A lot of water can go under that bridge. And by the end of the NICU stay, the parents might be a complete wreck, so to speak, and really be in need of assistance. So before parents go home, it's nice to know kind of what their status is and whether they're going to need extra supportive services once they do go home versus not needing that extra help.
What about online resources for parents? Parents often turn to the internet and social media for information and emotional support. So why do you think it's important for staff members, NICU professionals, to be familiar with these online resources?
Not every NICU has a parent support group, as we've already talked about. And so if they don't have their own support group, it would be even more important that they refer parents to online support groups such as Hand to Hold and others around the country. Again, parents just feel calmer and more in control when they have somebody they can talk to and share their experiences with. And even research has shown that doing it on the internet can be helpful to parents. So it's really great that there are quite a number of parent support groups on the internet that are well run and run by people who know what they're doing and sort of moderate the interactions between parents so that we know parents are getting good, reliable information.
Right. We want to make sure that if they are, I've heard people call it Dr. Google, but if they're out there in the middle of the night, which we all do, and looking for information, we want them going to the right places. So I think the work group recognized it was important for medical professionals at all levels to really understand and know what resources are out there and being consistent in making recommendations for these families so they can be part of a community and not feel alone and get that peer support that we were talking about earlier. So you mentioned going home a while ago. Leaving with my baby after 4 months in the NICU was one of the happiest days of my life and my husband's. But we were just so scared. We were terrified that we were going to be responsible for taking care of this micro preemie on our own. So what recommendations did the work group make in preparing our families to take home these medically fragile babies?
Well, the most important recommendation is to start involving the parents in the care of the baby from day one so that parents feel comfortable with their baby, learn how to, again, read the baby's cues, learn how to interact with the baby in a way that they can do with confidence. There's a lot of parents misinterpret their baby's signals. Premature babies can do things that actually make parents feel like their baby doesn't like them. And I've heard parents say, my baby doesn't like me. And that might be the baby's fussy. Maybe the parent hasn't learned how to calm the baby. Preemies will put their hands to their face and cover their face up and actually push away when they're overstressed. I mean, they have really good ways of telling us what they need at different times, but not all of us have really good ways of interpreting those signals. So the more we can engage parents to get to know their babies and to interpret their baby's signals, then the better prepared parents are going to be to care for that baby at home. I think another thing that's very critical is to give parents the opportunity to room in with their baby before discharge, which means, staying overnight or staying for 24 hours and doing all of the baby's cares while the nurse is still available to answer questions, but they're really on their own. And I wanted to kind of back up a little bit and just mention a model of care that's moving into NICUs, hopefully sooner rather than later, called family-integrated care. And this, we have all these designations: family-centered care, family-centered developmental care, family-integrated care. But what family-integrated care is a model that started in Europe of involving the parents 24/7 if possible. So that means having a bed for the mother in the baby's NICU space, preferably in a private room NICU, but not all NICUs are private room. So having a bed or a really comfortable chair where parents can actually stay overnight and participate in their baby's care and even sort of live in the NICU until the baby's ready to go home. So the studies done in Sweden and Canada on this model of family integrated care have shown that parents are more confident, they're less stressed, and the babies actually will go home earlier. There's a couple other things that were among the recommendations is that the doctors discharging the babies from the NICU need to follow up with the care providers directly, so like a call to the pediatrician who's going to be caring for the baby about any issues, risk factors for the family so that they'll all be prepared. Discharge coordinator should go over all appointments with the parents, make the appointments for the parents, go over the care practices, the equipment, and also do some anticipatory guidance with the parents about what to expect. For example, if the baby's discharged during RSV season, talk to the parents about the isolation they may feel, keeping their baby inside so the baby isn't exposed to RSV. Preparing the parents for comments people might make about what their baby looks like or how their baby acts. Those are all ways that we can help parents get ready for discharge.
I think that is so crucial. I often laugh about our rooming and experience because it was a horrible night. It was a horrible experience. We were so ill prepared and we were blaming each other because our baby wouldn't stop crying and neither one of us knew how to soothe him. So we always have laughed that they actually let us leave the hospital with him. But I think, just what a wonderful gift that would be to be able to have a space there and be welcome there 24/7, to really get to bond with the baby and be integrated in their care. I can only imagine what a better caregiver I would have been and how much more prepared, and I think a lot less frightened to take him home. So I think those are phenomenal recommendations. You briefly mentioned palliative care earlier, and I don't want to forget to talk about bereavement and palliative care. So can you give us some examples of NICUs? What can they do to best meet the emotional needs of families when there is a loss?
Sometimes losses are anticipated before birth. If the baby has a chromosomal problem or a major birth defect, we might know about those families, and those families might know about the NICU. So one of the first things we can do is just get together with those families before they actually arrive at the NICU to talk to them about what type of care they want for their baby and really let them be the architects of the care plan for their baby. Maybe they don't even want intensive care. Maybe they want to spend their time with their baby while the baby is alive. So it's very important for NICUs and hospital staff, including labor and delivery and the mother-baby unit, to have policies and order sets laid out for palliative care, if that is a choice that parents are going to make, so that it doesn't just fall on some nurse who happens to be on shift that day who's never taken care of a baby who's going to pass. We want staff people to feel equipped to handle this situation. And surveys of both nurses and doctors have shown that it's really one of the areas that they feel least competent, least prepared to manage is a death in the family. So doing training for the nurses and doctors and how to talk to parents about the situation is very important. Other things that are important when a baby passes is to offer parents a variety of bereavement rituals, such as bathing the baby, getting handprints and footprints, and other things. But again, make an offer to parents of you can do this, you can do that, what do you want to do? Take photographs of the family and so forth. And then finally, to help parents through the experience of losing a baby, some of that needs to be done in follow-up. So a phone call or a letter or card about a week after the baby has died that's been signed by the nurses and doctors who took care of the baby is meaningful to parents. And a care conference about 4 to 6 weeks after the baby's death is also important. I've done that many times myself and have found that it gives the parents time to process what happened, but also to think of a lot of questions, because when the event is unfolding in the moment, emotions can be so overwhelming that parents don't really know what questions to ask. And so having that time, about a month afterwards, enables parents to get all of their questions answered, I should say, and also gives an opportunity to go over autopsy findings if that has been done. So the doctors can really help parents understand what happened, why their baby died, and also to check in with them about how they're doing, how are they handling the grief process, do they need any referrals or outside resources to help them get through that experience.
Wonderful. Well, I know there were NICU graduate parents who are bereaved parents that contributed to these recommendations. So I think all of these are very warranted and needed and meaningful for the families. You talked earlier about staff education, and I just wanted to discuss for a minute that today's NICU families are very diverse, and their needs and their challenges are different. There's a lot of barriers for caregivers in, addressing those needs. There's language barriers and working with different needs of, non-traditional families, low-income families, multicultural families. There's single moms and teenage moms. I mean, it's just almost impossible to be able to effectively communicate with each one of these different kinds of parents and the challenges that they're going through. So I'm wondering, what did the work group propose for more effective communication for NICU staff when they're dealing with families in crisis?
The recommendations include staff education about communication techniques and also about culturally effective care. I think the most important thing about relating to all those different types of families is to check your judgment at the door so that we can really be open to all types of situations and just meet the parents where they are. Drop our expectations of what parents should be doing and just, again, meet them where they are. So communication needs to be respectful. We need to provide translators if English is not the first language. Communication should be transparent. Parents should be equal partners in decision making. And we need to try to identify what the barriers are to parents and families participating. As I mentioned earlier, parents may have barriers with transportation. They may not have a place to stay near the NICU. A lot of the larger NICUs will have patients referred in from the surrounding area, so parents may live an hour or two away from where their baby is being cared for. So having a NICU these days really means providing a lot of extra stuff to parents and families. maybe providing meals when they're there to visit their baby, providing shower facilities in the NICU if they're going to be staying 24/7, providing a space for them to sort of get away and lounge around, a space for them to have their meals away from the NICU. So the NICU is going to become like a little village that parents can enter and not even have to leave. At least that's the hope. Now, one of the real barriers that we face as a society is that we don't support leave from work for parents as they do in some of the European countries and other countries around the world. So when we talk about the family integrated care model and parents being there 24/7, well, that's really just not practical in the United States, where moms have to go back to work after 6 weeks and where we don't have the extended families to provide childcare for their other kids. So there are a lot of realistic barriers to all of these wonderful things happening, but we need to start somewhere, and we need to just do the best we can do for every family by providing whatever services we can that would be helpful to them.
Exactly, because what we're talking about is that, caring for a NICU baby really means caring for the whole NICU family. The entire family has now become the patient, and this is more than really just a shift in protocol. I see it as a kind of a sea change in philosophy that really it's requiring understanding that this, like we said, the mental, physical, social health of the family is directly correlated with the long-term physical developmental outcome of the baby. I just don't think we can emphasize that enough. I mean, this work group didn't just sit down and come up with all these recommendations to make life more challenging in the NICU. It's really about understanding that if we do this right, we can have a profound long-term impact on the development of the baby and the entire family's ability to take a very traumatic and difficult experience and thrive after the NICU. But that really requires that, the doctors, the nurses, the therapists, the child life specialists, pastoral care, they have to champion the adoption of these new standards, these new guidelines and recommendations, because if they don't champion it, nothing's going to change. And I thought it was really profound when you talked about earlier, we haven't seen a lot of breakthrough medicines and as where we can do some simple things to start and build up to the larger needs, but to have a truly long-term impact on the care of the NICU baby, but also the family. So where can NICU professionals go to read these guidelines so that they can print out a copy, that they could share it with their NICU directors and other staff? Where are these available?
Well, we have a website to support the recommendations, and the URL is www.support4NICUparents.org. And this website is basically divided into two parts, one for parents and one for professionals. So we have each of our 6 areas of recommendations for psychosocial support. They have pages with resources that include the articles that have the recommendations contained within them. There are lots of documents on how to accomplish certain things regarding the recommendations, lots of resources. There are links to other organizations on the internet that are doing work in the same areas. And importantly for NICU professionals, we have also a quality improvement page. The quality improvement page, again, has resources on how to do quality improvement in the area of family support. And so that starts with a tool we call our NICU assessment tool. And it has questions in each of the 6 different areas of psychosocial support that a NICU team can get together and rate themselves. It would say, for example, do you have a palliative care policy and procedure? Yes, we do. No, but we're working on it. Or no, we haven't even started on that. So NICUs can actually give themselves a score in each of these dimensions and an overall score. And then as they pick projects to work on, each NICU has to identify for itself where they need to improve. Like, we need to improve our rates of skin-to-skin care, or we need to improve by having a peer support program. So as they go through the process of implementing some of these recommendations, they can see their score improve. So I just want to direct people to that. All of the articles have links on that website, and also people can do a search on the internet for Journal of Perinatology, December 2015, Psychosocial Recommendations for NICU Support, and they'll find them.
Wonderful. Well, thank you, Dr. Hall, so much for being a part of this important initiative for really championing mental health of NICU families. I just personally respect and admire you so much, and I just think you have done more for NICU families in the past 10 years than most in the medical field. I just appreciate that you care so much and you give so much. I know how hard you work, and I know how many NICU babies you've cared for and how many families that you've cared for. So thank you again. Thank you for leading this work group and driving this and helping make it an important part of what we see can transition the NICUs in the future. So thank you so much for being a part of this today.
Well, thank you for helping us get the word out about these recommendations, and we are available to talk to anybody, answer questions. They can just write an email to info@supportforNICUparents.org, and we'll happily help anybody who needs it. We get inquiries all the time about how to start a peer support group, how to lobby with hospital administration for a psychologist, and so we have resources for all of that, and we're happy to help anybody.
Wonderful. Thank you so much. I appreciate you again, and look forward to reassessing how far we've come this time next year and ongoing as we make these recommendations to NICUs across the country. Thank you so much.
All right. Thank you so much.
Bye-bye.
Bye-bye.
We know that in order for NICU babies to thrive after discharge, they need smart, informed parents who understand their needs and are emotionally and physically capable of caring for a medically fragile child. Peer-to-peer support is an effective tool for helping parents navigate their NICU stay. Support from a caring and informed NICU graduate parent helps a new family feel more capable, confident, and ready to face the journey ahead. To request support, volunteer, or donate, please visit our website at handtohold.org.